Welcome. In this session, we'll be discussing language and selected higher order functions. Our objectives will be to describe the behavioral manifestations and anatomical bases of the aphasias, the agnosias, neglect, and apraxia. We'll describe the localization of function of Wernicke's area and Broca's area with respect to both the primary motor and sensory zones of the cerebral cortex. We'll look at the effects of damage to various parts of the perisylvian speech area, that is around the lateral fissure, on speech, writing, reading, comprehension, and repetition. We'll describe hemispheric dominance regarding language and handedness, and the contributions of the non-dominant hemisphere to speech. And then we'll give examples of the various disconnection syndromes regarding speech, and the role of the corpus callosum in particular in language functions. See some of the keywords that we'd want to focus on. Language we recognize as a symbolic means of communicating feelings, thoughts. It has both receptive and expressive elements, but it is a symbolic representation. We use words, an alphabet, and grammar to represent something that might be concrete or remarkably airy and not so concrete. Aphasia is the inability to use language. Dysphagia is an impairment in that ability. The behavioral manifestations and anatomic basis of the aphasias include two major kinds of aphasia: the fluent aphasias, known as Wernicke's area, which is that one that involves Wernicke's area, that is a receptive aphasia, inability to understand information that's coming in, and the Arcuate fasciculus damage produces another kind of aphasia, a conduction aphasia, in which it's, even though you might be able to understand, you might not be able to, things that are said to you or written, you may not be able to repeat them, even though you're able to speak spontaneously. The non-fluent aphasias, in particular Broca's aphasia, is an expressive aphasia, an inability to get words out. And we'll look at some of the details. And do take a look at these YouTubes of Sarah Scott, who has an expressive aphasia and shows recovery over an extended period of time. We'll also be looking at cerebral dominance and recognize that for the vast majority of people, the left hemisphere is principal hemisphere responsible for language, and it is not evenly distributed between the two hemispheres. And also recognize that language is learned. We start out without any language at birth. By 2 years of age, we have some good elements of learning of language, but it continues throughout many years. So it is dependent on some rather elaborate functions in addition to the basic sensory and motor functions we've been studying to date. Aphasia is the inability to use language. And the symptoms, and we'll be looking at a series of these, include Wernicke's receptive aphasia, conduction aphasia due to damage to the Arcuate fasciculus, Broca's or an expressive aphasia, and then an anomic aphasia, or just anomia, a difficulty in naming. And this can happen with almost any hard bump on the head, and it does not provide any localizing information about damage to the brain. And then mutism, the inability to generate any verbal output, has been associated with the supplementary motor cortex, an area anterior to the primary motor cortex. And we'll be looking at, in addition to the symptoms of the language abnormality, what other neighborhood signs, that is nearby brain areas, might be affected, and what signs and symptoms might be associated with that. We should recognize that following an injury to some portion of the language function, acutely, there often are very widespread effects, and it might be literally a mutism, and so it appeared much more severe acutely, and then gradually resolve to being much more localized as we see in a number of other settings. From the very beginning, acutely, there is a dramatic decrease in speech, even in people who will go on to have a Wernicke's area aphasia, where they might be able to speak quite a bit, but have difficulty understanding. So the difference between acute effects, which are generally much more widespread and severe than those over time. And by time, we're talking about weeks or months in which there might be evolution of improvement spontaneously, in addition to whatever specific therapy. And then we'll look for functional localization, different aspects of language in different parts of the brain. Recognize that the primary sensory and motor cortices, here we see the primary motor cortex, primary somatosensory cortex in the parietal, postcentral gyrus, motor in the precentral gyrus, primary visual cortex in the occipital lobe, primary auditory cortex here of the temporal lobe. Those occupy a very small amount of brain tissue. Much more of the cortex is what we might call association cortex, and almost all of the rest of the brain we would identify as association areas. That is in this somatosensory association area, visual association areas, auditory association areas. It is in these areas that we start to see higher processing of the basic sensory information and higher processing of the basic motor information in this frontal area. And we'll be looking at various other functions later on in the course. We see here represented both the primary motor, primary sensory cortices, primary visual cortex, primary auditory cortex, but now we see represented Broca's area just anterior to primary motor cortex for face. And that is in the opercular gyrus, triangular gyrus of the orbital frontal cortex. This whole area is orbital frontal cortex. It's the inferior frontal gyrus. And we also see Wernicke's area, and notice that Wernicke's area is close to the auditory cortex, and language is clearly a manifestation of early on and developmentally, it is an elaboration of auditory input. Certainly the auditory communication occurred much before any ability to interpret written material might involve the visual cortex. So the Wernicke's area certainly is immediately posterior to the primary auditory cortex. There are auditory association cortices right here that might be important in recognizing sounds that are nonverbal sounds and being able to understand them, but to understand language, the information has to get further back to the posterior temporal area, back where we see Wernicke's area, or to the angular gyrus. From the angular gyrus, it's clear that the arcuate fasciculus carries information from the temporal and temporal parietal area deep to the sensory and motor cortices to Broca's area, in this area in front of the face motor cortex that is in Broca's area. And that Broca's area is involved in expressive speech, Wernicke's for the understanding or reception of speech. We see some other areas beyond Broca's and Wernicke's area. We see the supramarginal gyrus, also involved in some aspects of comprehension, particularly perhaps the identification of phonemes. And we see areas that are involved in alexia and agraphia, that inability to read, also known as Gerstmann's read area. It might include a variety of language impairments. And then we also see, in addition to Broca's area, an area just above Broca's area known as Exner's area, and an area involved in writing, that is using the hand for language. And then up near the vertex, anterior to the primary motor cortex, we see an area that's called the supplementary motor cortex, and on the left side, that's a speech area, and damage here tends to produce mutism, although it is often transient. Note that primary motor cortex or cerebellar dysfunction may produce a dysarthria, clumsiness of speech, but not a primary language problem. The various aphasias are listed here that we've identified: Broca's, Wernicke's, and Conduction. And a global aphasia involves both Broca's and Wernicke's type of aphasia, and incorporates conduction aphasia as well. And we'll talk a little separately about transcortical motor and sensory aphasias. But recognize some primary measures that might differentiate these language disorders. Broca's area is non-fluent, and it's very difficult to get words out. Single words may be preserved, but grammatically sentences are very difficult to produce. It's very difficult to repeat what was said to you. Because it is in the frontal area, it is not uncommon to have some impairment of motor function on the same in the same region, and of course that would be on the opposite side of the body. And you might see a right hemiparesis. And of course that's from Broca's area, the left posterior frontal cortex, inferior frontal cortex, and the underlying structures. Wernicke's area, on the other hand, person often is fluent after some brief period of time, with abundant, well-articulated, melodic words, but comprehension of what was spoken to the person might be severely impaired, and repetition is impaired. In this individual, there are no motor signs, but the person may have some other emotional shifts. And that tends to be associated with the left posterior superior temporal cortex, and to some extent the middle temporal cortex. Conduction aphasia is a situation in which a person is able to generate words with good intonation, generally, but and comprehension may be preserved to a fair extent, but the capacity to repeat is most severely impaired, and this tends to involve the arcuate fasciculus. In global aphasia, it is a combination of these three, and there is very little language generated, very poor comprehension, and very poor repetition. And often that person has a right hemiplegia, and often that is a massive lesion in the left hemisphere, and it's most commonly seen in excuse me, in an infarct of the left middle cerebral artery, producing these language problems as well as the right hemiplegia. Transcortical motor aphasia is a situation in which input to Broca's area is impaired, that is anterior or superior to Broca's area, so that the information coming into Broca's area is inadequate. Comprehension tends to be preserved, but expression is very much impaired. On the other hand, damage posterior or inferior to Wernicke's area prevents sensory information from getting to Wernicke's area, so that comprehension is often severely impaired, even though the person may be able to speak and generate some meaningful sentences. These areas are represented in terms of these three measures: fluency, repetition, and comprehension, and the location of the lesion. So, of course, as we said, Broca's areas in the frontal lobe, you see decreased fluency, decreased repetition. Transcortical motor, you have decreased fluency, and the others a little changed. And that tends to be from frontal cortex above Wernicke's area. A global aphasia has all of these affected: fluency, repetition, and comprehension. And as you can see, it's largely the distribution of the middle cerebral artery. Wernicke's area shows mostly a decrease in repetition, comprehension, and the abnormality is primarily in posterior temporal and inferior parietal, perhaps. Transcortical sensory is between Wernicke's area and visual cortex and parietal cortex, and interferes with information getting into Wernicke's area. Conduction aphasia is usually from deep fibers in the parietal lobe between Wernicke's area and Broca's area. Alexia is an inability to read. It may be a feature of a receptive aphasia. Dyslexia, that is the impaired ability to read with a competence below that expected of a person's general intelligence. In the presence of normal vision, letter recognition, and normal recognition of the meaning of pop, is something that you see quite commonly in school. There's no clear neuropathology associated with it, but it suggested that there may be problems in parietal occipital areas between visual and area and Wernicke's area, functionally, even though pathology is rarely identified. Agraphia is the inability to write in the absence of any abnormalities of the limb, and it suggests of some problem anterior to primary motor cortex and perhaps just above Broca's area. Now, dysarthria is a difficult or unclear articulation of speech that is otherwise linguistically intact. And it may be due to a variety of insults, whether it's paralysis or weakness of the muscles of the mouth. It may be due to a part of a neuromuscular disorder, cerebral palsy, Parkinson's disease, multiple sclerosis, injury to the cranial nerves. Cerebellar dysfunction causes a dysarthria, slurred speech. It is not a language disorder per se, because the content of the language may very well be intact, but it not be expressed clearly. It's striking that this concept of cerebral dominance, about 70 to 90% of the people are right-handed, and about 10% are left-handed, and the other few are mixed. Almost all right-handers depend on the left hemisphere for language processing, somewhere between 93 and 100%. But most left-handers also depend on the left hemisphere for language processing. It's estimated that about 96% of people depend on the left hemisphere overall for language processing related to grammar, the lexicon, phonemic assembly, and phonetic production, all these various elements of language. The non-dominant hemisphere does have a role in prosody, the melody that you have of speech, the emphasis you give to some words over another. It contributes to the emotional impact of speech and helps to appreciate the emotion in the speech of others. In fact, the thought is that without the right hemisphere, you sometimes hear a much more mechanical type of speech than might otherwise be expressed. Although there is a preferential development of language in the left hemisphere, it appears that both hemispheres have that potential. Damage to the language areas of the left hemisphere at an early age, less than about 4 years of age, leads to a dominant shift to the right hemisphere. And in general, the earlier the damage to the left hemisphere, the more effective the shift is to the other hemisphere. Historically, language dominance was only able to be assessed in patients who had brain damage. If somebody had damage to the left hemisphere and lost language, you were concluded that language was located in the left hemisphere. Excuse me. More recently, methods can determine hemispheric dominance for language by injecting a fast-acting anesthetic into the left hemisphere. You can put that hemisphere to sleep briefly and see if the person's able to speak without that hemisphere. And that's done for certain medical purposes. And newer methods are available to locate language processing in the brain. Functional MRI is one, and positron emission tomography, and they are much less invasive than the water test. The corpus callosum is important for carrying information from one hemisphere to the other to fully carry out language. For instance, if you put something in your left hand and that information goes up to your right hemisphere, to know exactly what it is that you have held in your left hand, must go up to your right hemisphere first and then be transferred, that information from your right hemisphere transferred to the other hemisphere, that is to the left hemisphere, to get to Wernicke's area and eventually to Broca's area. So we use the non-dominant hemisphere to carry out verbal commands. We need the corpus callosum. One sample could be seen here of a flow of information. If somebody was asked to name something in the right visual field, that is over here on the right, that information would travel through the visual pathway, getting up to the lateral geniculate nucleus in the thalamus, from the thalamus to the cortex, from the cortex to higher order cortical regions, visual cortical regions, to get to Wernicke's area, and from Wernicke's area through the Arcuate fasciculus to Broca's area, from Broca's area to the facial motor area, to be able to be sent down to the cranial nerves of the face and or a pharynx to generate the words. So that would be the pathway for something coming from the right side of the body, whether it's visual or somatosensory. Information coming from the left side of the body would have to go through pathways that will end up in the right sensory cortices and then right secondary sensory cortices, whether it's visual or somatosensory, and then go through the callosum before getting over to Wernicke's area, and then go over to the Arcuate fasciculus, Broca's area, motor cortex, and on out. So we need the corpus callosum, and interruption of any portion of this pathway would interfere with the ability to name something occurring in the outside world, which comes initially to the sensory cortices and then travels through this pathway. It's clear that language is much more elaborate in the timing of the sounds that we generate. And this note was made of a preschool teacher said, "Look at this frickin' elephant," a student said. And the teacher was struck, and what did this call? It's a frickin' elephant, just look at the picture. And of course it does. And it reminds us that the pace of speech defines what it is we hear, what we understand. Other higher functions that we'll take a look at include agnosia and apraxia. Agnosia is a lack of sensory ability to interpret stimuli, sounds, objects, whether it's visual objects or palpable objects, despite an intact elementary sensory function. That is object recognition, either by sound, touch, or vision. The agnosias are mostly seen in bilateral cerebral damage in the sensory association areas, but may be seen with unilateral damage. We'll see some examples of this. There are several agnosias. An auditory agnosia is an inability to recognize the significance of sounds, for instance, a dog bark or a telephone ring, despite the primary auditory pathway working fine right up to the primary cortex, that is middle temporal gyrus, or superior temporal gyrus. Another agnosia is astereognosis, or tactile agnosia, the inability to recognize objects by touch, despite the fact that there's normal two-point discrimination in the primary somatosensory cortex works. This is associated with damage to the posterior parietal cortex. And the auditory agnosia is due to damage to superior and middle temporal gyrus around the primary auditory cortex. Color agnosia, inability to recognize colors of objects, separate from a retinal color blindness, can be due to damage to portions of the occipital cortex that are not primary cortex, but V2 or area 18. Primary visual cortex is V1 and also known as Brodmann area 17. Prosopagnosia is an inability to recognize faces or other familiar visual stimuli despite intact visual fields, and that's associated with inferior temporal occipital lobe, areas known as areas 20 and 21, even when the primary visual cortex is intact. There are many other named agnosias associated with each of the individual modalities and attributes. Some of the more unusual ones are asomatic agnosia, and that includes anosognosia, that is the unawareness or denial of illness, anosodiaphoria, an indifference to illness, oropac agnosia, the inability to localize and name various body parts, that is, a person could not name which is their pinky, which is their thumb, or asymbolia for pain, the absence of normal reactions to pain, that is beyond reflex withdrawal. Another feature that's a higher order function that's classically applied to the posterior parietal lobe, or possibly the superior temporal cortex, usually non-dominant, that is usually the right hemisphere, is neglect. It involves a complete lack of attention to the contralateral sensory field, whether it's visual, auditory, somatosensory, even though the person might have intact visual fields, they would tend to neglect them, ignore them, as if it didn't exist. And in fact, not recognize that what's going on in that part of the world. It's also sometimes associated with addressing apraxia or constructional apraxia. We see an example here of neglect in which somebody had drawn a clock, a model was drawn of a clock, a house, and a flower, and you see that when the patient who had neglect drew those same things, was asked to draw the same thing, they put all of the hours on one side of the clock, they built half of the house, and they built portions of the flower, neglecting most of what was going on the left portion of the field, maintaining some level of integrity of the right portion of the field. That's a contralateral neglect. Another higher order dysfunction is apraxia. It's a disorder of voluntary movement with an inability to execute purposeful movements despite the preservation of normal muscle power, normal sensibility, and normal coordination. There's normal cerebellar function. And it can be manifested by asking somebody to show how you would brush your hair or how you would comb your tooth. So even though their strength might be normal and basic movements might be normal, they're not able to carry out learned voluntary movements on command. The apraxias are seen mostly with damage to the premotor cortex, that is just anterior to the primary motor cortex, or in the parietal cortex, or the fibers that run deep to the motor and sensory cortices between parietal and premotor cortex. There are many different named apraxias reflecting the part of the body affected or the type of impairment demonstrated. Some of the symptoms of posterior parietal damage gather together in something called Gerstmann syndrome, and that includes a common left-right confusion, an agraphia, that is an inability to write, an acalculia, difficulty in carrying out calculations, and a finger agnosia, literally not knowing which is the thumb, the index finger, and pinky. Other features that might be seen of apraxia reflecting the role of the parietal lobe is idiomotor apraxia, inability to copy movements or gestures, commonly associated with left parietal lesions, or a constructional apraxia, where spatial organization is thrown off. And it can happen with either left or right. And you ask literally somebody to draw some feature, and they're not able to draw that feature. It turns out that damage to many sites may produce similar symptoms due to information flow, interruption of information flow. As we suggested for the corpus callosum, it may appear that somebody is aphasic when in fact information from a sensory region cannot get from one hemisphere to the other. They may appear to be have a receptive aphasia. But also lesions to the arcuate fasciculus, or the superior longitudinal fasciculus, which travels from the posterior hemisphere to the from the parietal occipital region all the way up to the frontal region. It may interfere with flow of information and lead to various apraxias. Apraxias are most commonly seen following frontal or parietal damage that leaves the primary sensory and motor cortex intact. An interesting feature of sympathetic apraxia is an inability to carry out a skilled movement on command using a non-dominant limb. And that is when somebody has had loss of their right hand, they might be expected to carry out a movement with their left hand. And while they may be able to do that spontaneously, when asked on command to use their left hand to carry out a command, they're not able to carry out the command. That's because the information coming into the brain has to get to Wernicke's area and get over to the motor cortex for the right hand. Motor cortex for the left hand. And that conduction may be interfered with by some pathway between Wernicke's area and the motor cortex on the appropriate hand. If there are any questions about these topics, we'll be exploring these in the coming cases. Recognize that our understanding of these higher functions is evolving. An example of that is given here at the end.